Well, I want to welcome everybody to our first ever PediECMO Journal Club, and thank you for taking the time out of your busy summer schedules to join us. My name is Elise Zivic. I'm one of the pediatric intensivists down at the Medical University of South Carolina in Charleston, South Carolina, and have been working with the PediECMO group, and we've been trying to get some of these journal clubs off the ground because we know that there's a lot of things that people that take care of patients requiring ECMO are really interested to talk about. And so we're hoping that this will actually be fairly interactive, and we encourage you guys to either throw questions into the chat box or raise your hands, and so that we can see. Caroline, I might need a little help with the chat box if you're okay with that.
Yeah, sure.
So we're also, we're hoping that this is going to be a little bit kind of like listening to a podcast, and we're going to interview the authors here of this study, and that way it makes it a little bit more interactive than just kind of going through the article itself. So just for those of you who are not familiar with PediECMO, it's it's a subgroup of PoliCE and ELSO, kind of a joint subgroup, where we are sort of a group of people that are interested and dedicated to doing research in patients requiring ECMO, and that's neonatal and pediatric patients requiring ECMO. And the group is there to sort of help facilitate projects, and especially facilitate projects across multiple centers, which is sometimes needed in this patient population. It's free to join, and we usually have meetings twice a year. In the spring is usually at the PoliCE meeting, and in the fall is usually at the ELSO meeting. And we're hoping to have a couple of these sessions a year. And so hopefully this one will go okay. So moving right into the session, I want to first thank the authors that are joining us today. So we've got Dr. Caroline Osment and Dr. Brianna Scott, who are here with us and they wrote this article last year, the anticoagulation and transfusion management during neonatal and pediatric extracorporeal membrane oxygenation. It's a survey of medical directors in the United States, and it was published in Peds Critical Care Medicine in June of last year. And so first and foremost, welcome you guys, and thank you so much.
Thanks for having us.
Yeah. So you guys wrote this with a couple other authors, is that correct?
We did. We wrote it with Mela Bembea, and who had done an original survey in 2013, and Phil Spinella.
Yeah. And so just in general, what was the reason why you guys wanted to do this study?
Yeah, it's a good question. So we started planning this study because Phil Spinella and I were working on doing or designing a multi-center randomized trial comparing anticoagulation monitoring strategies for pediatric and neonatal ECMO patients. And besides the fact that we knew that there was a lot still missing in terms of data out there to guide our study design, we also got the sense from discussions with colleagues and in BloodNet and PediECMO meetings that practices were definitely changing across centers. And so we thought prior to designing the trial, it would be a good idea to get a sense of where, take the temperature of what was going on in units a little bit more recently.
Great. And so this is a survey study, which I think some people think might be an easy thing to do, but I'm sure you guys encountered some hurdles during this study. Just in general, what types of hurdles did you guys encounter? And is there anything that you would give advice to people that are wanting to do similar studies about, survey work in general?
Yeah, so we encountered some hurdles, and then I've definitely learned some things about survey studies since we did this survey. I had the fantastic benefit of having Mela's prior survey to work off of. And we knew we wanted to change it a little bit because, hers involved more information on red cell transfusion as well. And we were looking at anticoagulation management, but I think one of the biggest problems we had was contacting, the widest group of ECMO medical directors available. And when Mela did her study, she was able to actually get the email list for all the ELSO centers, which wasn't available to us. I think they had stopped doing that as a practice by the time that we were doing the survey. So we had to we had to, come up with our own list using a variety of resources, and Brie will talk about that in a little bit. So that was one of the most difficult things that we encountered. And I think, if I've learned one thing from this, I've done 2 surveys since then. It's really to do as much pilot testing and pre-testing as possible prior to getting the survey out there. One of the things that survey studies have suffered from over time is the lack of a standardized practice to both design and report surveys. And since we published this, the Equator Network, which is the Enhancing Quality and Transparency of Health Research group, has come out with some standards for designing and putting surveys out there, and it's called CROSS. You can find it on the Equator Network website, but we didn't have that at the time. And so I think, really, designing a survey well and doing pilot testing and testing for clinical sensibility and reliability and validity is something that's really important and difficult to do. And so standardized recommendations on how to do that are important. And I think those are just now kind of starting to come to fruition. And then I think, one thing that all surveys suffer from is considering how to account for non-response bias, because it's definitely a problem. And ours wasn't terrible, but ours was actually pretty decent. I think we were somewhere towards 80%, but that actually took a fair amount of us, going out there and pounding the pavement, trying to make sure that we were contacting directors. And so, whether we created some bias with that or not is also kind of up in the air. And so it's tough because if your non-responders have a different opinion than your responders, you're definitely going to have more non-response bias. But if those that don't respond are really the general population and have similar variety of opinions, then it won't matter as much. It's just tough to know one way or another. So those were kind of the things that I found difficult in designing the study. And I think finding pilot testers that are really invested in pilot testing your survey and discussing and paying very close attention to the validity and sensibility of it is important. Everybody's busy, and so it's tough to find people to really weigh in as extensively as you hope they will. So I think those are the major things that I encountered.
Okay. And then you mentioned pilot testers. You guys had a version of this survey sent before. Did you also find pilot testers for the new survey as well?
We did. We use, I can't remember the exact number, but 3 or 4 pediatric ECMO directors, and then also actually an adult ECMO director as well in our pilot testing. And we had 3 rounds of pilot testing.
Okay, great. Well, it sounded like you actually had a pretty decent response rate, which is great. And I think that probably underlies, people are very interested in what these questions are and what other people are doing in their practice. And so, there's been a little bit of work around some of these questions before you guys published this study. And of course, you've already mentioned the study that was published in 2013. And can you tell us a little bit about what prior work in the field actually told us?
Yeah, so to kind of, summarize the big findings from the original survey in 2013. So that was done. Data was collected from 187 ELSO participating centers, and the authors found that 72% of centers reported using institutional protocols, 100% reported using heparin for systemic anticoagulation, and then a majority, about 97-98%, used activated clotting time in their monitoring, and 65% reported using antifactor 10A. And then regarding antithrombin activity, about 82% monitored antithrombin, and then there were very wide variations in transfusion thresholds. And then I think some of the other, since then, some of the studies, since 2013, some of the studies have demonstrated the volume of transfusion on ECMO is associated with increased mortality, as well as more and more studies, I think one of which you have listed here, on lab monitoring, showing an increased frequency of blood draws with ACT utilization, poor correlation of ACT with heparin dose and anti-factor 10A levels, and then poor correlation between ACT assays as well.
Right. So definitely some potential changes in the way that we monitor anticoagulation in recent years. And so that those were sort of the reasons why you guys wanted to see what people were actually doing now.
Yes. I think, there was kind of, I think both of the studies looked at these two studies that you have listed underneath the 2013 survey, kind of were looking at using anti-factor 10A either as like a single kind of assay and its feasibility. I believe that was the third study. And then the other one was kind of looking at PT, PTT, ACT, and anti-factor 10A, and kind of how those correlate with coagulation factor and heparin levels, both like in vivo and in vitro. And so both of those studies kind of were finding that anti-factor 10A is a pretty sensitive measurement of heparin change, and that it's potentially feasible to titrate heparin with that assay. I will say, I think there's two things sort of worth mentioning here based off of kind of what we know now is just as we move forward with this talk, the therapeutic range for anti-10A is not established for ECMO anticoagulation. So that's been extrapolated from different patient populations. And it's also important to separate heparin management and ECMO anticoagulation monitoring. So anti-factor 10A is a relatively clean measure of heparin, but it provides no information on what's happening with your patient. And so, since I think the ELSO guidelines have also kind of come out recommending against like single assay monitoring as well.
Going just sort of like through your methods, you guys already mentioned this a little bit, but you had to sort of find the ECMO medical directors by a different method. So how did you work that magic?
So we, so as Caroline kind of mentioned, that the policy kind of that historically existed was no longer as far as emailing ELSO centers. So we identified pediatric ECMO centers by, in the US, by cross-referencing ELSO reporting centers with the Children's Hospital Association. And so we were able to identify about 108 US children's hospitals, like ECMO medical directors. And then we were able to use the ELSO website, PediECMO, and then also just the group of authors' personal contacts.
And was there any concern about sort of leaving out potential ELSO centers since you didn't have quite that full list anymore?
Yes, unfortunately, that was a concern of ours. I think ideally we would have liked to obviously been able to know that we were reaching everybody and to potentially even, conduct the survey internationally. But there was, at the time, there was no way that we were sort of aware of to kind of make all of the contacts.
And my sense is that there aren't a whole lot of pediatric ECMO centers that aren't a part of ELSO at this point, at least in the US.
Yeah. For the survey questions, they were, as we talked about, from a lot from the prior survey, although it sounded like some of those questions had been from the prior survey had been taken away for another survey. And then these questions were fit into 4 categories. And for those that are interested, the supplemental content actually has the questions for the survey that you sent out. And then you ended up breaking down your data based on the presence or the absence of institutional protocols and age-based protocols. So, which was a little different than the prior studies. Why did you do it this way?
So I think as far as the presence or absence of institutional protocols, we were really just interested in seeing if there had been an increase in the actual use of an institutional protocol since the original survey. And there was. And then we were also interested in breaking down the responses based on age in anticipation of potential like future study design. We kind of wanted that information given developmental differences in hemostasis and things like that.
So now just to kind of look through the results, just starting off, we talked about 108 children's hospitals that actually received the survey, ended up getting 83 back, but after you sort of took out for some duplicates and things like that, you had about 79 total surveys included, which was, as you said, a pretty decent response rate. And then your first table in the results, this is just sort of about the general unit characteristics of the surveys that you got back. So tell us about any major trends.
Sure. Yeah. So most people that responded work in a PICU or spend time in a PICU and another ICU, whether that be a mixed unit, a cardiac ICU, a neonatal ICU. So you could respond to kind of working in more than one unit. The majority of program sizes reported held kind of greater than 16 beds and could support anywhere from 1 to 4 simultaneous ECMO runs. And then there were very few centers that could support more than 10 simultaneous ECMO runs.
Yeah, that's quite a lot. So most people were pediatric ICU based. And so from the results side of things, first things first. So you had some interesting findings in the survey. All people were using some sort of protocol. Was that expected at this point?
I would say, yeah, it wasn't necessarily, I guess, surprising. I think in the 2013 survey, about 72% of folks responded using using both anticoagulation and transfusion protocols. And so our survey revealed that about 79% reported using both. And then again, like you said, 100% used at least one type of protocol. And it was more often an anticoagulation protocol
Than a transfusion protocol?
Yes, correct.
Okay. Obviously, a big topic of conversation in our world is the use of or what type of anticoagulation people are using. And it seems like the use of direct thrombin inhibitors have become a hot topic lately. And lots of advocates for switching over to that being their primary source of anticoagulation. And in your last survey, only 100% of centers reported using heparin as their primary anticoagulant and only using a direct thrombin inhibitor if heparin was contraindicated, such in the case of HIT. And then that was a little bit different in this survey. Is that correct?
Yeah, so we had 5 centers that reported using BiVal as their primary anticoagulant, which I don't think it was necessarily surprising. I think there are even more centers than that use BiVal on a regular basis, but wouldn't necessarily classify themselves as using it as a primary anticoagulant. So I do think there's a trend towards moving in the direction of using BiVal more frequently.
So did you expect to find more people that said that they were using it primarily?
No, I think that response was what I expected. I know if we had asked more in depth about who was using it at times, but not as the primary anticoagulant, we would have had an increased number of centers using it that way. But I wasn't very surprised, potentially because I had already heard from those centers that were using BiVal primarily, among conversations with PediECMO and BloodNet, and then just in discussing the potential for upcoming research.
So the use of a secondary antithrombotic agent was something that we don't see a lot in the pediatric world, and you guys noted that in your survey as well. But that there are some centers that are using it, and some of them are pediatric centers.
Yes, it was definitely a minority of centers. I think, I think we added this question more so just sort of out of true curiosity to kind of see what, other centers were doing, especially given that some of these are utilized in the bad patient population. So it was more kind of just curious to see what others were using.
I believe it was like 9% were using aspirin, and then like 2% and 1% were using other things. Is that right?
Yes. Yep.
Okay. The antithrombin practice patterns, tell us about that.
So these were interesting. So when we looked at the practice patterns, about 97% of respondents reported occasionally or routinely monitoring antithrombin activity levels, but treating based on a certain level was almost equally split, 50-50. And then the majority who do replace antithrombin reported doing so with pooled human antithrombin. Regarding thresholds for replacement, those who reported that they did not use age-based protocols and those with neonatal specific protocols most commonly used, reported using 80% or less as a threshold. And the majority with infant or pediatric protocols used 60% or less.
Interesting. So definitely there's people that measure it and don't really replace it or don't have a standardized way of replacing it, for sure.
Correct.
Okay. And then what did you find out about trends in sort of the anticoagulation monitoring? That was one of your big questions or hypotheses as well too.
Mm-hmm. Yeah, so when we looked at centers who reported using heparin as their primary anticoagulant, which again was the majority, it was about 94%. Looking at all of the lab monitoring assays individually, anti-factor 10A was the most followed monitoring assay, although the majority of centers would utilize a combination of assays, the most common being anti-10A and ACT, followed by the combination of anti-10A, ACT, and PTT. And then there were centers that added viscoelastic testing to those already kind of aforementioned assays. And then regarding analyzing the data with goal ranges of the lab monitoring parameters, the majority use 0.3 to 0.7 units per milliliter for anti-factor 10A. And then for PTTs, the majority without an age-based protocol use 80 to 100 seconds, while the majority with an age-based protocol, regardless of age, report using 60 to 80 seconds.
So definitely seems like there's been a little bit of a practice change in how we monitor anticoagulation since the last survey. And then sort of the last other big thing was transfusion thresholds. Those look to be fairly similar from the last study. Is that what you guys observed?
Yeah, they were overall not too different. You know, we, like Caroline mentioned earlier, we didn't specifically look at red cell transfusions, but we did look at thresholds for platelet and FFP replacement. And again, kind of found that there continued to be sort of a wide variation. So when we looked at centers without age-based protocols, we found that fibrinogen level for FFP or cryo replacement was either, there were two kind of ranges of either 100 to 119 milligrams per deciliter or greater than 140 were used kind of most commonly. And then centers who do report using an age-based protocol, whether it be neonatal, infant, or pediatric, all tended to use greater than 140 milligrams per deciliter as their threshold. And then regarding platelets, regarding thresholds for transfusion, again, those without age-based protocols, and then those who have neonatal and infant specific, most commonly reported a threshold of 91 to 100,000. And then the pediatric thresholds were much more varied, with the majority using either 71 to 80,000 or 91 to 100,000 as a transfusion threshold. And I think later Caroline's we'll get a little bit more kind of into that with like the platelet and the taxicab things that recently came out as well.
Yeah. So moving on to the discussion about some of these things. And I think, you know, a lot of people, again, one of the biggest topics right now is like, what's the best anticoagulant to use? And so again, we just sort of touched on this earlier, the use of the direct thrombin inhibitors starting to become more popular as the primary anticoagulant. And so there's been several studies. So this is Seelhammer et al. They conducted a large retrospective study of patients requiring ECMO and compared heparin versus bival and saw lower mortality in the adult patients that were on bival when compared to when they were on heparin or compared to the heparin group. But interestingly, there was no difference in blood loss, transfusion, or ischemic complications, which you would think would be a part of what the mortality rate was from. And they didn't see any differences in circuit interventions or pump changes. And in the pediatric patients in this cohort, they did have less transfusion in the first 24 hours after going on ECMO, but otherwise no big differences. Another group compared bival to heparin on pediatric ECMO patients, and this was a retrospective study. It was 32 patients, had similar mortality between the two groups, but they had fewer bleeding events, less blood transfusion in the bivalve group. And then the thrombotic events that happened were also trended less, but were not significant in the bivalve group as well. And then Ryerson et al. Did a prospective study looking at 18 patients that included 20 runs over these 18 patients, the majority of which were VA runs. And they found that the rates of circuit interventions required were actually lower in the bivalve group. So there are some studies out there that show that the use of a direct thrombin inhibitor actually may be promising, but there are limits to those studies and limitations, of course, and such that the most recent set of guidelines from ELSO on how to anticoagulate our adult and pediatric patients basically say they need more study before they can say that they're superior to heparin. And so knowing this information, did you find that the increased use of bivalve, you mentioned that it wasn't really surprising and that you maybe thought people were using it more, even if it wasn't their primary anticoagulant. But knowing the recommendations recently that are not necessarily very strongly for switching to it as a primary anticoagulant, were you surprised that there was a 6% that had already?
Yeah, that's a really good question. I think sometimes as intensivists, we tend to be magpies, and like the newest exciting thing is fun and we want to do it. There has been such a push to move to bivalve in the VAD population with the Action Network protocol. And I really do think that has bled over into pediatric ECMO as well, since there's such overlap with the congenital heart disease population. And so I think it was natural for that to come over, knowing that many centers have switched to bivalve in their VAD populations. And I think, bivalve is an excellent drug. I think it has promising data coming out. Allie McMichael just finished a randomized control trial in Dallas comparing bivalve and heparin and ECMO patients, and the results are pending. But I think it has excellent potential, but it does have some issues too. There's kind of a ceiling effect at times with bivalve when measuring effect with the PTT, and there aren't great alternative monitoring strategies. There isn't quite a linear response when you use an INR, and then you can use a dilute thrombin time or an Ecker clot time, but dilute thrombin times are not widely available, and Ecker clot times aren't clinically aren't usually in clinical labs. And so I think it's tough to measure bivalve effect in an effective way in our patient populations. And we can talk a little bit more about the VAD patients, but I guess I am not surprised that people switched without having ECMO specific data based on the push to using it in the VAD population.
Do you think that we'll ever get to a point where we could have a similar protocol to the bivalve protocol that is put out by the Action Network?
Yeah, I mean, I think we could. The Action Network protocol wasn't based on data that bivalve was more effective or resulted in fewer complications in the VAD population. It was just a standard that was put forth, and I think it's fantastic that it's standardized VAD patients, and that will allow for better research moving forward and comparing mortality and morbidity using bivalve versus heparin. I think it's tough to apply that to the ECMO population, knowing how diverse the underlying pathology is, and the differences in inflammation and liver disease and all sorts of things that can impact the underlying coagulopathy in the ECMO patient. Certainly it's possible. I think it would be without a whole lot of data backing it.
Yeah, I think that's some of the things you've mentioned are the reason why a lot of centers have still not gone to bivalve as their primary anticoagulant. So yep. The jury still is out, I think, on the use of it, much to the dismay of some people. I think.
Yeah, I know. It's really such a hot topic these days, and it's tough because I think it's such an excellent drug, and there's so many benefits to using it. And heparin is such a complicated drug at baseline, and so it would be awesome if bivalve was the magic answer to all our woes, but I'm just not sure we have the information to say that it is yet.
Yeah. Another hot topic is antithrombin use. And so, there have been several studies over the last few years that have shown that AT3 can sometimes improve anti-10A activity, but has variable effects on sort of bleeding and thrombosis and mortality. And so your thoughts on the variation in AT3 replacement and measurements, and sort of even the thoughts about how varying levels of how people actually decided to replace that. Sorry,
Did we lose Caroline?
I don't know, we might have.
Well, I can answer, I think sort of going off this, I think one of the things that was, that we've been asked before was sort of the question that addressed the addition of antithrombin into anti-10A assays, and kind of why we looked at that, and do we think that that needs to be done more. But I think the point there that we were sort of looking at is that the anti-factor 10A assay measures the extent to which exogenous factor 10A is inhibited by complexes of heparin and antithrombin. And so some assays actually add antithrombin. So in a patient potentially who's antithrombin deficient, you could be overestimating your heparin effect and potentially masking an antithrombin deficiency, particularly if you're not necessarily at a place that closely monitors antithrombin. So I think the point there was just sort of knowing the assay your center uses will enable you to kind of accurately interpret the results, including taking into account potential antithrombin deficiency in your patients.
Yeah, that's not something I think that is taught very often when you go through fellowship or training in our field. And so you sort of have to have experienced it and know that that is something that is different depending on where you are. And so it's not surprising that a lot of people actually didn't know that when you asked them in the survey itself, what their local institution did.
Yeah, I'm sorry, I bugged out there for a second. I totally agree with Bree. I think it's tough, right? Like there's this huge move to using anti-10A as an assay to monitor everything, but if you aren't really sure of what the anti-10A assay measures and what it includes, it's really hard to say that you can effectively measure anticoagulation or even heparin effect, which is what I really think anti-10A assay should be used to measure. So I think it's really, really important to educate at local centers, just on what your anti-factor 10A measures and includes. And then, to know that you also are going to need to measure the coagulation stat or hemostatic status of your patient, because, all these ECMO kids have some underlying degree of factor consumption at baseline, which will not be reflected in the anti-factor 10A assay.
Right. Let's see now, platelets. So, there is data that platelet transfusions may actually be harmful. And there was a study that was done through the CAPCOR network that showed that increased mortality, it was not the TAXI study that's up here, but that increased mortality was associated with platelet transfusion volume, and that both thrombocytopenia and platelet transfusion volume were associated with adverse clinical outcomes. And so that led to sort of cautious statements from our sort of like recent publications about what levels people should or platelets should be replaced at. And so with this data around platelet transfusion potentially being harmful, what are your thoughts about the fact that the practices around platelet targets didn't really change very much in between the two surveys?
Yeah, I think platelet transfusion is such an interesting topic. Oliver is on this call, and I was just asking him if I could plug ecstatic during this talk, because there's a upcoming randomized clinical trial comparing a restrictive versus liberal platelet transfusion strategy that we're all really excited about. I think it's tricky because qualitative deficiencies in platelets are also common in ECMO patients. So even, knowing that you have enough platelets doesn't mean that you necessarily have enough effective platelets. And so it's really tough to assess the ideal platelet threshold in ECMO patients. So a lot of work still needs to be done. I think the fact that there was no change or not much of a change between the two surveys is not surprising. In Marianne's P3T point prevalence study that we did a few years back, it was relatively similar. There was a median transfusion level of 93,000 in that patient population. And then, certainly I think that it kind of dovetails with the recommended platelet threshold for the put out by the ELSO guidelines in 2018, which was 80,000. So we're kind of still in that same range. Studies have kind of shown conflicting results. There have been studies that have shown lower platelet levels being associated with increased mortality and morbidity. And then there are some studies that have shown that patients in a more restrictive platelet transfusion strategy group have done better. The Bates study showed increased mortality in patients with lower average daily platelet counts. But then there's a recent study comparing preterm infants between a liberal and a restrictive transfusion strategy, and those in the liberal transfusion strategy had worse outcomes, and they weren't ECMO patients. But I think the data is still kind of all over the place for platelets in these kids, and it's something that really we need to look much more closely at. So we're pretty excited about the ecstatic trial coming up.
Yeah. And so tell us more about the recommendation for antiplatelet therapy, that it be studied a little bit more in this patient population. It's not something I hear a whole lot of people talking about, as we saw in the results. Only what do we say, 9% of centers do aspirin as well as an anticoagulant, and a good chunk of those were adult centers. And so tell us a little bit more about that.
Yeah, I don't think it's a hot topic necessarily, but having until recently, I worked in both the PICU and the cardiac unit, and just seeing how frequently antiplatelet agents are used in the VAD population, and knowing how inflamed some of our ECMO patients are, it seems like a reasonable strategy to consider in our ECMO patients, especially in those patients that are a little bit more inflamed. And so it's just curious. Because it's not a hot topic, I feel like it's not talked about as commonly. And so I was curious if there were centers out there that really were using antiplatelet therapy on a regular basis.
You guys didn't ask specifically like how much antiplatelet therapy, right? Like didn't ask like 81 milligrams versus the regular dose.
Yeah, we struggled. We originally, when we put all our dream questions and tried to be as inclusive as possible in the original survey, we had red cell transfusions and why would you transfuse red cells, and aspirin doses, and all sorts of extra questions. But ultimately, I think with survey fatigue, it's tough to. You really feel like you have to keep the survey to a manageable time limit, and so some of those were questions that ended up getting culled out of the study.
Yeah. Well, and then sort of one of the last things that is also something that seems to be a hot topic is the increasing, sort of like use of thromboelastography and to help people decide what to do from an anticoagulation standpoint. And it seemed like 40% in the prior survey were doing it, and similar numbers, maybe a little bit more in the survey that you guys got, were starting to use it. And so what do you think about the future use of TEG in this patient population?
Yeah, I think viscoelastic assays are the future of anticoagulation monitoring. That's my personal bias, but there are no pediatric norms for our ECMO patients, and so are really not even for pediatric patients for the most part. And so until we have that, I think it's going to be tough to really move, mainly to a viscoelastic testing assay-based monitoring strategy. At Duke, we use it as an ancillary test. And I find it very useful when we have potentially expected discrepancy between the anti-factor 10A assay and whatever time to clot assay that we're using, which for us is usually a PTT. And so when those are really discrepant, we will frequently use viscoelastic testing to kind of reaffirm what it is that we think is going on with the patient. And so right now we're really using it as an ancillary test, but I do think that it is the future of monitoring.
sort of before we moved on, we had a comment back around talking about our bivalve. And I think really just saying, that bivalve has a pretty short half-life. And when used in bypass surgery, any stasis of blood in the chest will turn into gelatin. And we've seen this in ECMO circuits with low flow or no flow spots in the circuit or situations. VADs have more of a continuous washout, and bivalve may have a better outcome. And so I think that's an important point. It's one of the downsides to using bivalve in these patient populations. And I know we've had a circuit, like some of those low flow areas around pigtails and things like that in the circuit. We have trouble with clots, and certainly have to think about switching kids back to heparin when you're ready to do low flow trials on them, if they're on VA, things like that. And so definitely one of the reasons why it's not necessarily like why people haven't totally switched over.
Yeah, and I think a number of those studies actually had people on heparin first, and as they went on to ECMO and then transition. So certainly there's a period of time there where you may have risk for increased clotting or bleeding, and so I think it's tough to really say that switching all the way to bivalve is the way to go right now. I really just don't think there's enough data to support that.
So from a future study standpoint, talking about like getting data. So, first of all, it seems like a majority of centers have some sort of age-based protocol or protocols in general. And when designing a randomized control trial potentially in the future, do you think it would be something where we'd have to look at like NICU versus PICU versus cardiac ICU specifically, or we could combine these cohorts?
I think it's tough. I think ideally we would split them into the separate cohorts, but I think getting the numbers to get meaningful data when we split will be difficult. I think in the ideal scenario, we could account for some of the confounding factors, like inflammation and liver dysfunction and medications the patients are on. And then, of course, there are so many other significant confounders like circuit setup, which is highly variable. We actually did a parallel survey to this survey looking at circuit setup, but the circuit setups that were reported were so wildly variable, it was really difficult to even report on them. And so I just think there's so much to be accounted for. It's going to be tough. It's going to be tough either way, which is hence the reason we still haven't figured this study out. I mean, COVID kind of set us back a little bit, but a lot of this stuff was setting us back as well. So I think ideally we would separate them. Ultimately, I won't be surprised if we need to combine them to get the data that we need to get.
And so is that sort of like those are the greatest hurdles you see to sort of the development of equipoise with a randomized controlled or a multi-center randomized control trial?
I mean, I think there's definitely equipoise. I think just developing a trial in a manner to get meaningful results that apply to all the populations included is what's going to be difficult. Ultimately, Phil and I decided we probably really needed to go back to a lab to start, with initial phase in a lab looking at thrombin formation in a circuit without a patient attached with whole blood, with bivalve and heparin at different doses, and measuring true thrombin formation as well as the anticoagulation monitoring assays that we do on a regular basis, and then potentially even add in some markers or some pro-inflammatory things as well to see what happened with the circuit. But we haven't gotten to that point. We haven't gotten funding to be able to do that at this point. So I think we're going to probably need to start in the lab and then move to the patient. So we're open to any suggestions that are out there from any of you on the call. Yeah. We've presented this several times at PediECMO too and gotten some good feedback, but still have some hurdles that we haven't been able to overcome.
Sure. Well, any other thoughts from you guys about the study or anything else that good insights that you guys had that we haven't talked about?
I don't think so. Covered
Anybody, any other questions from people that are listening or things that they want to bring up? We've got a few minutes for questions. All right.
I just really want to congratulate all of you. This is an it's really, it's excellent. This just should be widely made available. Congratulations.
Thanks,
Well,
Olive.
thank you guys for joining us. You know, we're hoping to do more of these, you know, sort of quarterly or something like that through PediECMO, and we'll, you know, definitely look into the YouTube. That was a good suggestion, because we're patiently waiting on a website that I think may be coming for Polisi soon. And so, but yes, we'll work on all of that stuff. And we really appreciate everybody joining, and we will make the recording available. One comment did just come up that was also about the studies. I think variability not only in centers, but patients will make this very tough to determine the best practice. So yes,
Absolutely.
that's always an important point. So again, thanks for everybody for joining and participating, and we really appreciate it.
Thanks for having us, Elise.
Thanks for having us, Elise.
Yeah.
We're proud to be the first one.
Yeah, good job.